Well, good evening, everyone. It's a pleasure to be here, every month for the European Knee Society hot topic. It's a privilege, today to have Professor David Barrett from London, England, Southampton, worldwide experts, in the knee surgery with us, and we're going to talk about the difficult topic of, patellofemoral replacement. Patellofemoral joint is often the forgotten part of the knee, but we know that the patients suffering from patellofemoral arthritis, they have at some point a miserable life and they deserve an appropriate treatment. Of course, conservative treatment is an option, and when it doesn't work anymore, we can always discuss a total knee replacement, but we know that the best patients are the ones where you can offer partial knee replacement or small implant. They can be really successful, but only if we understand the indications and the surgical challenges or technical tips and tricks. So David is definitely the expert, and we have the privilege for the next 20 minutes to listen to him. He's going to teach us, how we should do if we want to be successful with patellofemoral replacement. And then with Michel and also Manu Tiampon, who's going to join us, we're going to debate, discuss, and maybe challenge him a little bit. You're going to have the option to ask him questions, so feel free to use the chat. And now, David, the floor is yours.
Thank you very much, and Sebastian, Michel, good evening, everyone. It's a delight to be here. Let me just start up my presentation, and then we can just set the scene for what I hope will be a great discussion. So I agree with you, Seb. The patellofemoral prosthesis is indeed a hot topic, and when we think about it, it is the most challenging compartment of the knee. It's certainly the least developed in terms of what we've managed orthopedically. And I have to say, I think it's the most neglected. And when you said it was the forgotten joint, I'm afraid that is true. It's most neglected, but it's highly symptomatic. As a primary presentation with isolated PFJ OA, it is no doubt highly symptomatic and often presents young. And these people are maltrackers. They've maltracked all their life. And so they're presenting to us with real symptoms between 40 and 50 years old, so much younger than our standard total knee replacement. And so we're aware of that as a primary presentation, but also it's a significant issue for 20% of our total knee replacement patients. So those of you listening to the webcast tonight may say, I'm not really interested in isolated PFJ, but actually this affects every one of your total knee patients as well. So the joint itself remains an enigma. And I believe that PFJ is the joint that will develop and change most in the next 10 years. So orthopedically, if you were looking for a topic to be interested in, to perform research on, PFJ is the correct subject. And this is one of the reasons. This is the National Joint Registry data, and the green graph is PFJ. So you can see the lines below are the total knee replacement, and then the purple line is unicompartmental. So unicompartmental have a higher rate of revision. PFJ has 6 times the rate of revision. Now, these are historic cases, but you can see whatever we're doing with PFJ isn't quite right yet, which is why it's interesting and, if you like, a hot topic. So why is it going wrong? Why have we got 6 times the revision rate when we've got all this instrumentation, lovely instrumentation that we can use to put in PFJs? And this is some of the detailed stuff we have. So why is it going wrong? Why do we have 6 times the failure rate? What are we doing wrong? And the failures in PFJ are early, and it's certainly not implant failure or wear, but it's related to pain, maltracking, instability, effusion, clicking. Now, we should really take a leaf out of partial knee surgery with Cartier. And so Cartier told us a uni is not half a total knee. And as a result, we've become much more sophisticated with our unis now, and we recognize it's a completely different operation. We'll cut the tibia at a different angle, we'll position the femur in a different way. So operating on a uni is not a total knee, it's not half a total knee, it's a completely different operation, and we've learned that. And we see success now in unis that match that of total knees. So equally, patellofemoral is not a third of a total knee replacement. And yet, if you look at that instrument on the left, that is clearly an intramedullary glide that's been adapted from a total knee set. Okay, and we're still thinking of a patellofemoral joint as the anterior cut we make for a total knee. And so you can see, for instance, that total knee position is driven by the fact we cut the tibia at 90 degrees. As a result, we have a 3-degree external rotation that we have to put in order to compensate for that, because we need a flexion gap that's parallel. But the orientation of anterior cut and the trochlear position are determined by the total knee landmarks. And we're using the same total knee instruments, IM rods. Landmarks are the posterior condyles, Whiteside's line, and the transepicondylar axis. So that 3-degree of external rotation is a compromise for total knee surgery. It's not a requirement for the PFJ. So we're using all the techniques for total knee to make that anterior knee cut for a PFJ. And I'm saying it's not necessary, and it's maybe wrong. So when we learn about PFJ, we can't learn it from the x-rays. We cannot start looking at alignment or measuring angles. It's a dynamic, mobile structure. So the way we've learned about PFJ is to actually instrument a cadaver knee and move it and reproduce those movements in a virtual knee. So you can see the cadaver knee on the left. The virtual knee only exists in the computer, but is driven by the sensory input that we've got from a cadaver knee, because the patella moves in 3 dimensions, and it's a lot more difficult to visualize that than, say, the tibiofemoral joint. And so what we have for that is some data, much more important data now on the patellofemoral joint. And one of those is actually the patella doesn't spend very much long in the trochlear. It spends a lot more time in the intercondylar notch. What spends all the time in the trochlear is the extensor hood. And you can see how the extensor hood wraps itself around the trochlear now. So actually our trochlear design, our trochlear orientation should be a lot more, we should be a lot more aware of the soft tissues of the extensor hood rather than just the bony anatomy of the patellofemoral joint. Because when we look at the patellar contact forces, we can see they're relatively physiological. So blue and green in these studies are physiological force. Red is supra-physiological. So that's why it doesn't really make a difference whether we resurface the patella or leave the patella natural in total knees, because the forces are not really very extreme through the patella, and the bone and the plastic are relatively insensitive. And so historically, 20 years ago, when 90 degrees was acceptable as a total knee outcome, you can see that anterior knee pain wasn't such a big deal, because the force of the patellofemoral compression went straight through the bone into the plastic of the polyethylene. So we never really saw anterior knee pain as a significant issue. As soon as we get to patellofemoral resurfacing or a high demand knee, where we'll see more extreme flexions, you can see that the force is going not through the patella button or the bone, but actually through the extensor hood. And that extensor hood is highly innervated soft tissue. So understandably, they feel pain if there's an issue with the trochlear position or the trochlear orientation. So when we use our model to try and predict some of the stresses we'll see in total knee replacements, and here you can see we've replaced the knee and run the program again, you can see the red areas are actually in the front of the knee here. And I'm using my marker here. You can see there in the extensor hood, inflection is where the trochlear drives itself into the soft tissue, which is highly innervated. That's when we get supramaximal forces, which give you anterior knee pain. So suddenly it's become all about the interaction with the trochlear and the soft tissue in the extensor hood than the patellofemoral joint itself. And so we have to understand a little bit about the changing character of the patellofemoral joint. And it's a little schizophrenic, if you like. The key angle in the change of character comes at about 30 degrees. Before 30 degrees, the movement of the patella is variable on the fairly flat surface of the trochlear, and it's relatively unconstrained and lightly loaded. The retinacular fibers will guide the patella on that flat surface until about 30 degrees. Now, at 30 degrees, the patella commits to the groove and becomes anatomically stable. It becomes constrained, and heavily loaded, much more heavily loaded. So you can changes its character from being unconstrained and lightly loaded and variable in its track to highly constrained, much more significantly loaded and invariable in its track. So there's a big change in character in the patellofemoral joint. So if I can remind you there, we can see as the knee is straight, there's a lot of laxity in the patella and it's held only in place by the retinacular ligaments. As soon as we bend the knee, the patella is locked in the intercondylar notch, the retinacular ligaments become loose, and the patella is tightly constrained and more significantly loaded. And you can see I've got a picture of the foot in the top right-hand corner. And that's because the patella tracking will be influenced by the rotation of the tibia, or the rotation of the foot. Because as you internally and externally rotate your tibia, will internally and externally rotate the tibial tuberosity, which means you'll influence patellofemoral tracking. And that's important to realize as well. So if we take the foot straight and bend the knee, the patella will move down the center part of the trochlea and then at 30 degrees commit to the intercondylar notch and be held rigidly in place. What I want to show you is that not only is patellofemoral tracking different between individuals, it is different every single step that individual takes. So let's say the first step for me is with my leg straight, and this is my patellofemoral track. My next step is with my foot externally rotated, as you can see from the picture. So the patella starts on the lateral side, is guided by the medial retinacular ligament to the center point of the intercondylar notch, and then it's recruited into the intercondylar notch. So that's my second step. On my third step, I internally rotate my foot. And you can see the patella starts on the medial side of the trochlea, is dragged across by the lateral retinaculum, and then commits to the groove. So in 3 steps I've taken, we can see the patella tracks in 3 different ways. So in effect, the trochlea is acting like a funnel. It's recruiting the patella from wherever it lands in a multitude of places and delivering it to the center of the intercondylar notch where it's ready to take load. So how should that change their surgical approach to the PFJ? And you can see this is a common problem you see with maltracking of the patellofemoral joint. A lateral subluxation, a failure to commit, and if we did this in a total knee, we would actually alter the position of the patella to accommodate the position of the trochlea, which is dictated by the flexion gap. The rotation of the femur is dictated by the flexion gap. And so what we effectively do is a metal trochleoplasty. So these patients have lateral trochlear hyperplasia, they maltrack, and that's why they've worn out early. So if we did this like a total knee, we'd say this is unacceptable and there's a huge patella tilt. So we would perform a metal trochleoplasty. We would capture the patella. So this is a phrase that was used 10 or 15 years ago about making sure the patella was rigidly kept on the front of the knee. So that's our transepicondylar axis or our posterocondylar axis as we do a total knee. And so we would position our patella trochlea or patellofemoral trochlea in this way. And so we would have captured the patella as we would have done total knee surgery. The skyline views would look great, but you can understand the soft tissue tension in the lateral retinaculum was extreme. And these patients had great x-rays, but a lot of pain. And the pain caused them to be revised. So this is one of my x-rays that I did about 15 years ago. And I thought it was probably the best skyline view I've ever had. But you can see that you can understand that this patient had pain. So the x-rays look great, but when you think about it, the soft tissues over this old-fashioned, broader patella trochlear implant were under tension and impinging on the sides of the metal. So this patient was revised even though the x-ray looked great. So nowadays, we have a different concept of the soft tissue sensitive. The positioning of the trochlea for a patellofemoral joint should not be the same as for a total knee. So we're going to position our much narrower trochleas within the shoulders, the natural shoulders of the native trochlea. So that means that we're actually going to replicate the trochlea tilt, which allows us to keep the patella orientation the same. That means the patella will track in the same way as it's always tracked, and the tension in the lateral and medial retinaculum is exactly the same. So we don't see problems of maltracking, clicking, dislocation. We don't try and capture the patella. So this is how patellofemoral surgery is different from total knee surgery. And that's why I think we should move away from the total knee landmarks when we do the anterior cut for a trochlear in patellofemoral joint resurfacing. So this is a little bit train and tracks concept, okay? So if we have the train off the tracks, what we have done in total knee surgery and historically is just put the train back on the tracks and get a normal x-ray. That's caused us a 6 times revision rate. So a different way of doing it with patella malalignment is put the tracks underneath the train. And that way we have a well-orientated soft tissue envelope, which is a source of pain in patellofemoral replacement. So if we look on how we should do this, so this is a right knee, and I'm preparing the patella at the moment. What I'm doing at the moment is circumcising the patella. And this has got nothing to do with trying to cut the nerves of the patella. People often talk about this as releasing the patella, but all I want to do is take away the scar tissue around the patella and allow me to stand the patella vertically in the intercondylar groove. In terms of preparing the patella, I'm driven by the bony apex, okay? So I want my polyethylene apex to be in the same position as my bony apex. And that way we can ensure that we're not changing anything in the knee and causing abnormal soft tissue tension. Now, for this case, I'm using an inset patella. And the reason I'm doing that is so I can keep the bony anatomy around the implant and not disturb the soft tissue connections. You can use an onset patella, but currently an inset patella is what I prefer to use. So once we've decided the size of the inset patella I've used, you can see that by my landmarks on the tendon and on the suprapatellar pouch there, we've managed to get the polyethylene apex in the same place as the bony apex. And this is not about maximum bone coverage. It doesn't really matter how much bone you cover. It just means that the apex of the patella is in the same place as the bony apex of the native patella. And you can see what I'm anxious to do here is to make sure my transitions between the polyethylene and the bone are as smooth as possible, particularly on the lateral side of the patella. So the plastic and the bone need to match perfectly. So I'm taking away the osteophytes now that are inferiorly, superiorly, and particularly laterally, again, because that will cause a little bit of impingement. But if I've done my job appropriately, we will see that by reproducing the patellar anatomy, this should track perfectly in the native trochlea without using my thumb. And what I'm looking for is bifacet contact. So at the moment, you can see that I don't have to even close the retinaculum. The patella will find itself naturally on the front of the trochlea. So we see this from the side now, and what I'm looking for is bifacet contact through the whole flexion range. So having replicated exactly the position of the patella apex, what I need now to do is reconstruct the trochlea in exactly the same position without changing. So I do not want to capture the patella. I want to mimic exactly the patient's native trochlea. So I'm marking here the trochlea groove and the outer aspects of the trochlea. It's key that I don't overhang on the outside because that's where we get soft tissue impingement. So I'm very keen to match naturally the medial and lateral dimensions. And you can see my orientation here is just to the center of the trochlear groove. And you see the jig is marked in its center, and we've managed to get that exactly on the trochlear groove, and we are not overhanging. And so my position now has got nothing to do with where the tibial tuberosity is, the external rotation, internal rotation of the femur, the epicondylar axis, or the posterior condyles. It's all to do with shape matching the trochlea and making sure my metal trochlear groove is in the same orientation as the native trochlear groove. Now, this means I can't really use a jig because all the jigs are set up for a total knee, if you like, philosophy. And they will cut related to the posterior condyles and the transepicondylar axis. So I'm afraid this has to be a freehand cut because I'm replicating a quite complex three-dimensional anatomy for which I can't use a saw. So we're using a high-speed dental burr here in order to relieve the trochlear anatomy so we can let in the trochlea in the same orientation as the patient's. Now here, I'm making my first match, and I'm not happy that we've got a good transition between the metal and the bone. So this is a matter of just trying to get the correct match here to make the transition as smooth as possible. In this particular case, I need to do a bit more work around the lateral side. And you can see now, I've particularly got a good transition on the lateral side between the metal and the bone. And this is key to make sure that there's no clicking or jumping of the patella, particularly on the lateral side, as most of these will be lateral maltrackers. So you can see what I'm doing now is loading in the trial implant to make sure it's as perfect as possible before we cement in. And the key here is that if the transition and the passage is correct, we will not need to even close the medial side or even think about a tibial tubercle osteotomy, because we've actually replicated the natural patella tracking. So you can see I put the patella back again. I'm doing the same thing without using my thumb. We've got easy passage of the polyethylene patella on top of the trochlea, which has been orientated to the native patella. So that's how we do it. Don't change anything, and don't use total knee joint, if you like, orientation or landmarks. So now, what about balancing the third space? So I'm calling this the third space because the flexion and extension gaps are the first and second spaces, yet the third space is that patellofemoral space at the front of the knee. And this is important. So let's say green is a perfect size of implant, whether the implant is a patellofemoral trochlear or a total knee. If I overstuff that, and you can see that we've got a presence of blue now, that has a huge effect on the soft tissue. Overstuffing the third space, we can show, makes 7 millimeters further quad tendon travel and increases the quad pressure by 1.7 times. So that's almost twice the pressure on the quads by overstuffing that third space. So these patients have normal looking lateral x-rays, but will tell you that there's a tight band around their knee all the time, and they feel that they're under a lot of pressure at the front of their joint because the quads are twice the pressure because of the overstuffing. Now, let's take the red option, which is understuffing the third space. So that introduces quads laxity into the tendon, and so the quads will work 2.3 times harder to get full extension of the knee. So again, the x-ray looks okay, but as they walk upstairs, for one flight of stairs, they do 2 flights of work, and they will tell you they always feel exhausted or fatigued after doing work on their knee because they're working twice as hard. So that trochlear offset is hugely important in the third space. So until recently, we haven't been able to characterize this in surgery. And what we can have, and this is relatively new, well, actually very new, is an ability to dynamically measure the pressure measurement in the PFJ as we're doing the surgery. So this is work that we've done between Southampton, Milan with Angela Brivio, and also in Pittsburgh with Jonas Plate, who's one of the surgeons in Pittsburgh. Recently published work, which I'd like to present right now, about how we measure that patellofemoral force. So what we have in the process of doing knee surgery is a 6 millimeter sensor. We take 6 millimeters off the back of the patella, and that sensor is then put on the back of the patella, and the patella is reduced onto the front of the native knee. We have 4 sensors there that are collect, if you like, the superior, inferior, medial, and lateral pressures in that patellofemoral joint. So first of all, we collect the data from the native knee, and we bend and flex the knee, and this is 5 cycles of flexion and extension. And you can see the different levels of medial, lateral, inferior, and superior pressure as we go through those 5 cycles. And what we see is that the 5 cycles are reproducible, the pattern is reproducible, but it's also individual to each patient. But it's very consistent. And so this is just with the patellofemoral sensor in on the native trochlea. Then we go ahead and either do the knee replacement or we do the trochlea replacement. And then we repeat the data collection and observe how the pressure has changed in that articulation. So you can see in this example, we can see there is a reproducible pattern in those 5 cycles, but the shape has graphically changed. And we can see that we've lost a lot of the height there in these graphs. So that means essentially we've understuffed the patellofemoral joint, and we're going to lose power from the patellofemoral joint. What we have now is we can substitute on the center a number of shims that replicate changing the depth and angle of patellofemoral resection. So what we can do now is change the thickness and cut of the patella so we can replicate what was in the native knee in our replaced knee. So there's on our left what we've collected from the native knee. Then we compared it with what we had after we did the trochlear replacement or the femoral replacement. And now by cutting or using different sensors, we can see we can alter that pattern. And what we want to do is choose a pattern that is closest to the native knee. So you can see this one is far too overstuffed. So that's too much pressure in the patella. That one's a little better, but the pattern is different and the blue is much higher than the yellow. This one, again, is too much pressure, and it's the wrong orientation of blue and yellow. And probably this one is the closest to our native. And we can therefore choose that particular sensor and then cut the patella in the right way to get the pattern that most resembles the native patella pressures. So we now have a cutting jig that we can program in to cut at that particular angle and the particular depth in order to do the correct patellofemoral pressures. So that avoids over or understuffing and maintains the function of the third space. So with this new work on patellofemoral loading, we can actually show, we can dynamically monitor the patellofemoral loading. We can show that the knee produces consistent and reproducible pressure patterns, and those patterns vary in between individuals. What is important is they're very significantly altered following total knee or patellofemoral resurfacing. It's completely changed. And we can adjust the patellofemoral resection for depth and angle so that the patterns resemble the natural state, which avoids some of the anterior knee pain, we very much hope, and might be the key to third space function. So in summary, it is indeed a hot topic and there is much work to do. We need to learn from the uni that the patellofemoral joint is not 1/3 of a total knee, and we need to stop doing it with the same instruments we use for a total knee and just adapting them a little bit. And we certainly can't use the same orientation that we use for the cuts on an anterior flange of a total knee. There are specific alignment and tracking requirements for people who develop abnormal patellofemoral wear as a result of malalignment. And they're entirely different from people who develop osteoarthritis in later life that affects the whole knee itself. So currently, I use a freehand trochlear prep to replicate the native trochlear orientation. So I think there is an application for robotics here, because obviously a robotic can be programmed to cut very accurately the complex three-dimensional shape of a trochlear rather than relying on my freehand technique. I think there are aspects of patella design that I haven't discussed here because we don't have time, but we can actually remodel the patella design so we get much more effective loading of the patellofemoral joint. But what we have seen is there are huge consequences of failing to balance the patellofemoral joint, the third space. And that makes our patients very symptomatic and very uncomfortable. And what we've just shown is we have new instrumentation to establish and adjust the patella and the extensor hood loading, which might be useful in the future operations that we do. Thanks very much for listening. I look forward to our discussion.
Thank you very much, David. Now we have Emmanuel Tiampon joining us. Manu, thanks for being there. I think, David, you the fantastic talk as always. We already have a few questions before we start the discussion. We can start with the ones from the chat about, you discussed a lot about how we can play with the patella when resurfacing and not overstuffing or understuffing. But what about just leaving the patella as it is? Just doing a implant on the trochlea. Well, could it work?
Okay, so there is some data on that. I can absolutely see from Derek has written to me saying, well, look, it's can we do it without the patella? I totally get that. And you would think that because obviously in a total knee, we can't tell the difference whether we use the patella native or where we resurface it. The results are the same. What I would say is this is another example of how patellofemoral resurfacing is not the same as a total knee. There are two studies that have tried to leave the patella native in patellofemoral replacement. I'm afraid both show that they get very inferior results. The patella is highly symptomatic in a malaligned patellofemoral joint. So I would say to Dirk that I would always resurface the patella in a patellofemoral joint resurfacing. I don't think it makes any difference in the total knee. The other point I think you made about an inlay patella, I think it's a very much, I'm not sure whether we have any good data on this. I don't mind whether we use an inlay or an onlay, but what I found with an inlay is I can very accurately get the dome in the same position as the apex of the patella. So it's quite appealing.
I have, I have a lot of questions for you, David. I will maybe ask one because we also have expert in custom implant here with Manu and Michel. Why not? Because you are obviously a gifted surgeon. You can do this freehand, technique, but it's not easy. You mentioned robotic. We can discuss this later on. But why not going for a custom, PF joint replacements?
So I think in many ways, actually, it's an ideal opportunity to think about that. And Michel hopefully will have some thoughts about it as well. But the joint surface is very irregular, and it changes from patient to patient depending on how they've worn. So in many ways, what we're doing is taking a metal trochlear and we're doing our very best to adapt it to the orientation of the patient's own trochlear. So I would say this is one of the areas where, because the anatomy is so variable, actually a custom-made trochlear would be very reasonable.
Manu, Michel?
Yeah, absolutely. Congratulations, David. A fantastic talk, really. But I do agree. This is a fantastic indication if you would be able to do it. But I asked it to the American custom implants company that I've done some work with in the last 2 years, and they basically don't want to do for the economic model. So maybe Michel can comment on the Swiss company he works with, but they don't want to do in the US, they don't want to do the design work, planning, PSI jigs for an implant which doesn't bring enough money. Michel?
Yeah, that's another problem, because there is the industrial process discussion and there is the design and conceptual aspect. I think that obviously, due to the variation of the orientation and the shape of the trochlear, it should be customized. But customization means reproducing the contours, reproducing the anterior offset, reproducing the orientation, and this is already a great thing. And then the possibility to do that industrially depends on the process. And the company for which you are speaking about doesn't customize the trochlear for now, and probably don't have the knowledge and the technology to do that. And also the regulation can be also in some countries a big problem.
Yeah.
But honestly, I think that the customization of the trochlear improves a lot the result. In fact, there is a the thing is that the more you reproduce the native shape of the knee, the better you are, and this is true for the patellofemoral joint and for the tibiofemoral joint also.
Yeah, but that would be a question for me to David. David, you show a technique where you kind of resurface, but you resurface in the pathological situation. So, what would happen to the implant if you see that the native tissues, usually around 55 years in dysplasia, developed away? So, what do you think? Is the implant going to last also 55 years, which would be great? Then even you would survive it. You will get 110, I think. But what do you think? Is the implant resistant enough to take it on the long run?
So that's really, I mean, frankly, Emmanuel, I'll be lucky to be here next week. Never mind in 110. But so you're absolutely right. So, and this was always the argument that people would say when you say, oh no, you must correct it because this is why it's worn out, because it's malaligned. And so if you put your implant in the same orientation, you must expect it to wear as well. We must correct it. And I think that may be true for a load-bearing joint, and I can see how people would want to do that. But increasingly, particularly with the patellofemoral joint, everything, although, okay, in skyline view, it's not perfect, it's actually tilted. But as I've shown in my diagram, that means that the forces, both the trochlear and the patella match, and therefore the forces in the soft tissue also match. What we do is when we try and capture the patella and sit it on top of a straightforward anterior knee cut, like in total knee surgery, what we're doing is altering the soft tissue forces and actually causing pain. So I agree that what we're doing is setting up a malalignment, but it's only a malalignment of the patellofemoral joint. And we're putting an implant in that has and we know when we use cobalt chrome or polyethylene, we can expect it to last 20 years. Within that patellofemoral joint, although it's at an angle, the loading of the patella button is equal. It's when we put it in straight, the loading is unequal because it's still trying to push on the lateral side. So we are adjusting our orientation, but we're adjusting it to make it in line with the forces of the knee.
Yeah, but you didn't show any x-rays of your resurfacing procedure. I saw the x-ray of the classic centrally aligned patella. So how do you protect your patients against all your friends and colleagues around you who will probably tell them that this is a badly aligned patellofemoral joint?
That's right. Yeah, that's right. So so you're right. So I haven't shown any of those, and I could dig them out and maybe show them at the end of but they are tilted. So you will see that the patella is in the same position. The trochlear is orientated under the patella, and it sits within the trochlear shoulders. So yes, I mean, someone could say, oh, I think that's wrong. But as I say, it's very different to the sort of standard view that I showed you.
Yeah.
I agree with Manu, because the first thing the guys are going to do, they're going to do a CT scan, and they're going to use the usual numbers we use for total knee, as they're going to tell you, look, the trochlear is so mal rotated, you have to revise it. I've seen that. That's a pure misunderstanding of patellofemoral replacement, but
I'm afraid it is. And we've just had a patient sent to us who has had a robot patellofemoral resurfacing done. Okay, but you can see from the skyline view, it looks perfect. And what they've done is the robot has very accurately cut what they put into it. So they put in the total knee orientation, the transepicondyle axis, the posterior condyles, and the robot's gone ahead and cut the trochlear, but in a perfect position for a total knee. So the patient has pain and dislocation. So it is how we program the robot. You're absolutely right. But yes, we have to educate the patients to say, look, it is going to look a bit odd, but it works.
David, you said that if the patellofemoral joint is centrally aligned, as we all used to do it, and patients are painful, you will revise them to a total knee. But how do you solve that issue then? Because is that really the answer for a painful patellofemoral joint, a total knee?
So I think what happened, and I actually then because I thought that too. I thought, why am I revising this to a total knee when really the joint is pristine? And the answer with a total knee is you are much more in control of the kinematics of the joint. So once you've excised the tibiofemoral joint, once you've excised the cruciates, you're actually making a joint that's much less demanding, and the patella will actually track on that horizontal anterior cut that you've made for a total knee. And it's because you're taking out all the kinematic drivers when you do a total knee, and the movement becomes much more simple, like a hinge. And I believe that's why you address some of the soft tissue pain. because we've got the cruciates, because we've got all the ligaments, the menisci, the knee is still moving as a natural knee when we do a patellofemoral joint. And so that's why we have to operate within the kinematic envelope of the natural knee. When we do a total knee, we're getting rid of the natural kinematic envelope, and we're putting in something less demanding that moves in a less physiological way.
Okay, before we go to the questions, because I see fantastic questions that Sepp will read to you. I have a last question because it's really related to what we discussed now. So how do you think the impact is of the VMO, which is in dysplasia, also dysplastic? So the medial vastus muscle, how can we optimize this in a dysplastic patient with a patellofemoral joint? Do you think this is exactly the oblique position that you use that gives some more maybe offset on the medial side where the muscle is weaker and that helps them more? And what we lose with our symmetrical cuts, or do you have any opinion about it?
I think that's a really great thought, actually. You're absolutely right. They are weak on the medial side, and the physiotherapists will spend ages trying to get them to build up their VMO to try and control that tracking. I think if we orientate the trochlear so it follows the patellar track, we are not so we don't have to work so hard on the VMO because we don't have to try and bring the patella more medially. What I find is that once they've lost their pain, is that they actually will build up their muscles because it's not painful anymore. So I think there is a natural increase in muscle bulk, but because we don't need the patella to move anymore immediately, I must admit I don't immediately focus on the VMO.
Okay.
I will, as Manu said, maybe consider some of the questions from the chat. One is about tibial tubercular osteotomy combination with PF replacement. Do you have some indication? You mentioned, medial lateral tilting, but still also sometimes the patella is too high, too low. Do you manage that in some way?
Right. So actually, when I first started this, there is, and this is, I think, this is Tamer has asked that question. Yeah. So Tamer, when I started doing patellofemoral resurfacing, I actually did quite a lot of tibial tubercle osteotomies, and probably about 15 or 20% of isolated PFJs. And I was doing that because I was still using my total knee anterior cut. So I actually had to use the tibial tuberosity to try and get my patella to sit on the top of the knee because it was trying to go laterally. Since I've changed my orientation to follow the natural knee, I haven't found it. It's very, very rare that I would do a tibial tubercle osteotomy to try and medialize the patella because I don't need to. So putting the tracks under the train has meant I do less soft tissue surgery to address medial lateral patella tracking. What I still do is I do a distalization osteotomy. So a lot of these people with malalignment have patella alta, and patella alta is one of the contraindications for patellofemoral resurfacing. If the patella is sitting above the trochlear, your danger is that it won't engage. And so the times I do a tibial tuberosity now is if I want to draw down the patella to have it sit on top of the trochlear because it's too high up.
David, just to comment, what do you do when you have like a chronic dislocation? So you had a dysplastic patient who had a chronic dislocation of the patella. Okay. Usually they come around 40, so very young, with osteoarthritis, but chronic dislocation. How do you treat them?
Yeah, so that's really, really difficult. I'm not sure I know the correct answer to this, and I'd be pleased to hear what you and the guys think. But so I think that I would always say that a dislocating patella is not an indication. So some people think they control a recurrent dislocator by giving it a patellofemoral replacement, and I don't think that's the case. So when the patella is dislocated, like actually not in the trochlear notch, I get very worried about how my patellofemoral joint will do. So I think that if they were symptomatic and we've ended up with patella on that lateral side, I think that's when you do have to consider some artificial soft tissue measures, and that would be the time that I would try and replicate the trochlear position as if you like externally rotated as possible, but actually use a tibial tubular osteotomy or a medial capsular plication or reconstruction to place the patella on top of the trochlea. I think they're very, very difficult cases. I don't know what your experience is, or Seb's or Michel, on those difficult cases.
Okay, I have a remark, David. I love your presentation because it's a sort of a revenge of the anatomy. And what I like in your conception is that you don't link anymore the patellofemoral joint and the tibiofemoral joint, and this is why it's easier to have good outcomes. And you said that in TKA it's easier, but in fact, I think it's more difficult because in TKA the problem is that the patellofemoral joint is the slave of the tibiofemoral joint, particularly if you do kinematic alignment, because you have absolutely no margin of alignment of your patellofemoral joint because you are linked to the tibiofemoral joint, and this is a very good way to have new ideas. All these anatomic studies. What do you think?
So when we started designing patellofemoral joints, we tried to work out what the anatomic landmarks we would use for trochlear orientation. And so there's a method where you can take a whole load of variables and just drop them in the computer, and it does an analysis about what are the most significant variables. And we did this with the University of Dublin, and they found the trochlear orientation has absolutely nothing to do with any of the landmarks we use for total knee. And when you think about it, that makes sense, because the patellofemoral joint develops in isolation to the tibiofemoral joint in a different time and a different place. And what determines the trochlear orientation is how the patella sits on front of the femur. So very much how the head of the femur molds the acetabulum. So I absolutely think it is completely separate from the total knee. And of course, when we start using total knee landmarks, then of course we're trying to marry them together. And then we end up with this conflict, as you point out, with kinematic analysis, where we're driven to the trochlear position.
Yes, we must think more phylogenetic. You're right.
That's right.
Yeah.
No, I think that's, what you say is exactly what we feel, like Michel said, with kinematic alignment, with off-the-shell implants, and we realize that the problem is the trochlea, because it's definitely not, related to the femoral tibial joint. It was the same with the Deuce implant. We're trying to, to resurface the, medial compartment and the patellofemoral compartment linked together was impossible. We know that bicomp should be a, different implant, not linked together, or maybe with custom implants, maybe, but not with something off the shelf. So that's you put this, the way you think about this is just moving forward now, and like Michel said, we just consider more the anatomy, the physiology of the knee, and that makes a lot of sense. I just remark about the robotic. I think the way you tell the robot to do is the problem, not what the robot did. So the robot is just a tool. I think the guys had just misunderstood how to make the plan, because when you have a 3D model of the knee, it's also a nice way to do exactly what you show, but with your hands. You can ask the robot to do the same. Probably, David, if I give you the robot, you will do the same with the robotic tool.
No, I think, and I can see how it would be such a great operation, because basically you could register the trochlea. You could say, you could get that picture up on a robot. You could actually orientate the trochlea exactly how you wanted to sit in that groove. And then you could say to the robot, get on and do it. So I can appreciate that would be a great use.
We have a question from Angela Brivio about the tourniquet. We didn't discuss this. Should we use a tourniquet or not when we do patellofemoral joint resurfacing?
Okay, so that's a really great question, and to be honest, it's a practical question, but I think that it's a really important one if we're thinking about doing this. So the cases that I've done recently, I've ended up actually releasing the tourniquet and then noticing that any little doubt I had about the tracking has gone away, because as soon as you untether the quadriceps, that does make a difference to the way that it will track. And so I think Angela's point is really good. So in future, what I'm going to do is that we're actually going to take the tourniquet off and assess the final tracking without the tourniquet on. So I do operate with the tourniquet. For those of us who don't operate with the tourniquet, they have an advantage. And I think what I would do is actually release the tourniquet. So that's a great if you like, take-home tip, if you're thinking about patellofemoral resurfacing, take the tourniquet off as you, or rather deflate the tourniquet as you assess the patellofemoral tracking.
I have other questions. If Manu and Michel, feel free to jump in, of course. I don't want to monopolize the microphone. What about the approach? You use mid-vastus, subvastus, transquad? Do you consider sometimes using lateral approach? What's your feeling about that?
Okay, so that's a good question. So I actually do a fairly standard approach that I would do a total knee through. So it's through the center of the quads tendon, and then a paramedial approach. I don't go a subvatus. I don't go into the quads muscle at all. I don't think there's a huge problem with that, and I don't think it probably makes any difference on that medial side. What I haven't done is I haven't done it through a lateral approach. That's an isolated patellofemoral, only because I think it's quite difficult to evert the patella when you're approaching from the lateral side. And I want to make sure that I get my polyethylene dome in exactly the same position as the bony dome. So I really want to see that patella. So I've tended always to do it from the medial side.
Manu?
Yeah, David, there are a few third generation designs from the big four companies usually. Do you think it makes a difference what the trochlear angle is? I mean, the angle between the lateral condyle and the medial condyle, and also the Q angle, as they call it, these are two parameters that are different. Do you think it makes a difference, or is it really the technique as you showed, and can we do that with any design?
Okay, so I think the Q angle becomes less important in patellofemoral resurfacing. So it's a key thing in total knee replacement. And as Michel pointed out, you're a slave to the tibiofemoral joint. So your tibiofemoral joint will be like this, and your Q angle will have to be at a certain angle in order to allow patella tracking. Obviously, with patellofemoral replacement, we can orientate the trochlea how we like. So I'm not sure that the Q angle makes a huge amount of difference. I think what does make a difference, you talked about the angle between the medial and lateral sides. And so how we make that angle, how deep we make that angle does make a difference. And now we're a little more intelligent about how the patella moves. We'll find that angle changes at different parts of the trochlear implant. So it should be relatively flat to allow the patella to skate medial and laterally an early flexion. And then we'd want to see a deepening of angle as we led into the intercondylar groove, because we know the patella is going to become more constrained there. So I think what we'll see is a little more intelligent design. And like you say, with that third generation, we're seeing that a bit more now, that they're deepening that angle as we go into the intercondylar notch to get that transfer.
And David, we speak a lot about the trochlear, but do you think that the design of the patellar button has also a role? Between a dome, oval, sombrero, do you think there is a margin of progress or evolution? What are the lacks of the current designs?
So I'm so pleased you've asked me that, okay? Because that's the bit I couldn't put in my talk because it would be too long otherwise. And so absolutely, I think it's crazy that we're putting in domes, okay? Just to put the cat among the pigeons, okay? So if we look at the patella, it's not a dome, okay? We spend a lot of time trying to match the femur, and we talk about J curves and how we want to make it as natural as possible. And then we put a polyethylene dome, a spherical dome in the patella. So the patella is not convex at all, it's concave. And we've got a dome because it actually compensates a lot for surgeon error in placement and also in tilt. And so that's why we've used a dome in the past. And I think what we've got now is a lot of data to say that it's not the coronal thing that's important, it's actually the sagittal control of the patella. And so as soon as you start tilting in the sagittal plane, you begin to lose the quad's function. And so what we can say is that by remodeling the dome, and taking it from a sagittal contour of a convex surface to a concave surface that fits better the curvature of the femur as the quads pull it, we can show that you can actually increase quads efficiency by 10%. What happens with a dome is it just tilts up as soon as the quads work, and you lose a lot of power in the quads as it happens. If you keep it close to the femur, you can make a big improvement. And I think that's the next important change we'll see, Michel, in design of the patella. Several implants already have an anatomic patella out there, and we can show that they're much more efficient.
Yes, but anatomic is strange because when you cut the patellas, they are all different shapes after the resection, and the manufacturer provides you only one shape. And you know, I would like sometime to have round ones, to have oval, to have but you are trapped by the design of the manufacturer.
Sure, that's absolutely right, and that's why a dome was so appealing, because although it resembled nothing like you were taking off, it would sit in 3 dimensions and rock from side to side. Okay, and what we've shown isn't so good for quads efficiency. But you're right, the patella is continuously variable. The only thing that is about an anatomic dome is that obviously now we've controlled the shape of the femur. We know what the shape of the femur is because we've just replaced it or resurfaced it. So that's how we get away with an anatomic dome, because we know exactly what shape the femur is. So the anatomic dome will fit exactly the shape of the femur. I think if we were to talk about putting just a patella surface on against a native trochlear, that would be a huge issue. I think we get away with that a little bit because we're controlling the shape of the femur.
David, if you would be in a case where you would not be happy about the lateral soft tissues and you feel that there is some tension, can you give for the audience some tricks how they can do some type of lateral release? And I don't mean just cut it and cut the 2 arteries. What are some tricks?
Okay, so I guess my big message about lateral release is the operation of the devil. Okay, so I'll make this, okay? So no one will forget that this is what a lateral release is like, okay? It's the operation of the devil. What we're doing is we've already cut the medial side to go into the knee. And if we cut the lateral side as well, we've taken away the 2 retinacular restraints, which are the only thing holding the patella stable in that first 30 degrees of flexion. So if you cut the lateral retinaculum, it's like letting all the ropes go on a boat and the boat will just drift out to sea. So I don't think we should do a lateral release. I think you may have got the idea there.
Yeah, but David, you say that because intrinsically the lateral retinaculum release is dangerous, or because it is the proof that you did something wrong?
Yeah, that's true. So I think that's right. So if you were doing a total knee replacement and the knee dislocated as you flexed and you thought, gosh, my lateral side's too tight, I want to do a release. Well, absolutely, you've got something wrong because you've got the femoral rotation wrong or you've overstuffed the patella. So absolutely right, Michel. As soon as you start thinking about doing a lateral release, you've done something wrong. Okay, so that's great. But as Manu was saying, there will be a time when you're doing isolated patellofemoral resurfacing that you'll see the patella drift off laterally, and you think, oh, that's not the tracking that I wanted. Okay, what I'm saying is that the boss who taught me how to do this would say, just do a lateral release, and I'm saying I don't think we should do that. So I think there are 2 reasons for doing that. So I think. If you have the patella going laterally and you're not happy about it, I would do exactly what Angela was talking about. Angela Brivio was that release the tourniquet, because you want to make sure that you've got the quads free and you're not having an issue with that. And then I think rather than do a lateral release for a patella that was tracking laterally, I'd rather do a tibial tubercle transfer, because I want to keep those 2, if you like, in English we talk about the guy ropes or the tether ropes on either side of the patella. So I'd rather do a medialization of the tibia just to bring the patella across.
Yeah, I was thinking more of, the soft tissues that were a bit tight. I was not talking about dislocating patella. So what we usually do is either we do a lateral fascectomy with a saw, because we believe that if you take the lateral bone off, it's like an internal lateral soft tissue release. And if it still would be on the soft tissues on the lateral side, we would needle it a little bit. That is what we would do. But it's, of course, because we don't do the resurfacing technique as you do, but we do
No,
the
I think that's really good point, Manu. And what I do is with you saw me do it with on the video. You saw me do it with the bone nibblers, but actually I would always take that lateral osteophyte out. So it's a great point because it will cause the patella to deviate laterally. It's an unphysiological structure. So absolutely, I do a lateral facetectomy, take that lateral facet out. And I think that if the soft tissues are a little tight and you feel that's the only thing that's making them tight, then I'd rather do a sort of a Z release rather than just cut the lateral side. But yeah, lateral facetectomy, entirely legitimate. I wouldn't call that a release.
Well, guys, I think we're just reaching the 1 hour that we usually consider to be a good time for this kind of expert discussion. I think it was a fantastic way to close this first year of European Knee Society Hot Topic with our current president, Professor Barrett.
Thank you.
A very nice topic also, PF joint replacement. We had a really nice discussion, a lot of questions from the chat, so that was really good. We are currently working with Michel on the program for the next year and waiting for the approval from the board coming very soon, I'm sure. So I think, Michel, we are really looking forward to next year, and having, another year of European Knee Society Hot Topics, discussion. This being said, I would like to thank Emmanuel, David, for being with us, today, and wishing you a great evening with a glass of wine, David. I'm sure when you're going to be back home.
I'm definitely going to be in a glass of wine the size of a swimming pool.
Fantastic, and see you very soon. Take care.
Bye,
Bye, guys.
Bye-bye.
Bye.
Bye.